Hi, everyone. My name is Chiou, and thank you, Susan, for such a great introduction. And I'm just honored to be on kind of the prevention side to present a little bit of what we're excited about on the technology side to help us here. So I'll be presenting on the realities of AI for melanoma detection. I have no relevant industry disclosures. So I think I'll start off by just an intro to the premise of why we think AI could be so helpful to help us catch melanomas earlier. So I think anyone who's ever dealt with melanoma, whether personally or professionally, really gets that the sooner you catch melanomas, the better, because we know that portends higher likelihood of surgical cure, better outcomes overall. And when we talk about how we do this, lots of people have done a lot of research on how we can orient our entire healthcare system to really help people catch spots as soon as possible. And so you'll frequently see pictures like this, where our current state is where a patient comes in with a spot of concern, and in most cases presents to a general clinician, oftentimes a primary care provider. And then that individual has to make a very astute assessment that, gosh, this spot might be a melanoma, or it might be something else that's bad. And then they escalate that case to a specialist, oftentimes a dermatologist or some other specialist who will help then guide that journey to diagnose and treat that spot. And truth be told, the system can work really, really well. I just want to give a real world anecdote. This is at Stanford Healthcare, a recently diagnosed real life melanoma. This appeared on the back of a gentleman, middle-aged man who presented to his primary care doctor. That primary care doctor did a physical and saw this multicolored irregular spot on the patient's back and had that astute assumption that this is something that might be bad. And so put in what's called an e-consult, where they send a picture over to dermatology that same day, highlight his concern. My colleague, Dr. Chiou from the Melanoma Center, saw this and said, oh my gosh, sound the alarm. Called a bunch of nurses, doctors, ended up 3 doctors, 5 nurses, and multiple people at clinics got involved. This patient ended up in the clinic within 24 hours, biopsied, diagnosed with a thin early melanoma. I'm pretty sure someone here cured that, or did a surgery in a timely manner. This is exactly how we want this to go for patients with a melanoma. But we know that when it comes to diagnosis, you'll recognize that the dermatologist has the easiest job. Many people have already seen this spot, been concerned, elevated up. My colleague, Dr. Chiou, all credit to him. He spends all day looking at skin spots. So to him, he could pick this up very easily. Many of the critical people are that primary care doctor or that patient who maybe has never seen a melanoma before and has to make that assumption that, gosh, this spot is bad. I need to trigger the alarm. So that's where the promise of AI might be. Can you take some of that expertise that lies all the way downstream to the dermatologist and bring some of that up to people higher up who can make that critical decision? Because we know in the real world, across the country, that critical decision doesn't always get made or gets delayed. And that's why we really want to bring that expertise up. So this is what Susan referenced. I think this is where the Stanford part of the story starts. So in 2017, members of our pigmented lesion melanoma clinic, including Dr. Sweater, Dr. Chiou, collaborated with some brilliant computer scientists at Stanford, and they asked, could AI help us pick out melanomas from normal skin spots? And they showed in this landmark Nature paper that the AI could actually perform at the level of a dermatologist in picking out skin cancers and melanoma from normal skin spots. However, big constraint. This was a very, very constrained, we would say contrived experimental setup. These were textbook historical pictures that were fed into the AI, and then they were tested on that as well. And since then, I think we've become a lot more wise as to what AI can do. So these are colleagues from Memorial Sloan Kettering, whom we collaborate a lot. They have put real-world pictures of spots, not classic textbook pictures, to the AI. And what they're finding is that the performance drops significantly. When you take more real-world pictures, these are melanomas that may have scabs on them. A hair is going over it, or the lighting is a little bit off. Market drops in performance. And sometimes these algorithms perform very unpredictably. In this case, in one of the top performing algorithms, if they encountered a skin spot that's not been seen before, half of them get called skin cancer, calling it essentially causing a false alarm. So this is why our group has now kind of turned to become a lot more focused on real world testing of these algorithms, understand beyond the hype of that initial paper and these contrived test sets, how would this happen if we actually brought it into the clinic and used it on a patient we were worried about? And on the left is kind of a laundry list of all the reasons why in the real world, spots are way harder to diagnose by AI. One of the big things is that in dermatology, we're not like the radiologists. A chest x-ray that goes through you looks pretty similar here in California, in Chicago, and in New York. But from clinic to clinic, we use different lights, we take pictures with different cameras, patients have different colored skin tones. There are a lot of curveballs that these computer algorithms are being thrown. And as a result, they oftentimes go wrong, or we call it generalizability. They can't perform the same way in which they were developed at our hospital compared to where it was initially made. I just want to walk through one example in detail here, because I think it really shows you the challenge of AI in dermatology. So here's a classic AI diagnosing algorithm. So essentially, it's been trained on tens of thousands of moles, thousands of melanomas. So if you give it a picture of a mole, it's going to be pretty good at saying, hey, that's a mole. But we know in the real world, there are thousands of types of skin spots. And if the person seeing a spot is not quite sure what it is, and they put that into this algorithm, in this case, this is a basal cell skin cancer, which looked a little bit like a mole. And if you put that into that algorithm, which hasn't encountered many of these types of spots, there's a good chance that algorithm is going to say, don't worry about it. It's a mole. It looks just like all the moles I've seen before. So this is why our group, who I'd say, you see that team on the left, that's the group that really opened the door to AI in terms of early melanoma diagnosis. I think we've also felt the responsibility to understand what are its weaknesses and how do we pilot it so that it can actually be very useful. So this is a big 3-year effort that we were very lucky to have been funded by the Melanoma Research Alliance, and just kind of finished, where we partnered with the Cleveland Clinic to really put algorithms to the test and ask what would happen in the real world. So we recruited over or close to 800 patients and over 1,000 lesions. And big picture here is that we recruited them prospectively. So we didn't use historical classic textbook pictures. We said, anyone that comes through the door, if you're worried about a spot, we want to see how this performs in this real world scenario. And then we took 4 state-of-the-art algorithms and put them to the test and compared how they would have done compared to what the dermatologist ended up recommending. And long story short, we saw really big drop off in the performance compared to what they're supposed to do on paper. If you look at the original Nature paper, again, talking about dermatologist level performance, well, you look at that same algorithm, which was actually improved for this study. And what we actually saw is that its ability to detect a skin cancer. So if you have a skin cancer, the chance of it telling you that it was correctly a skin cancer was only 28%. And then what we found is it made a common mistake. It thought skin cancers were inflamed skin spots like acne pimples or eczema. So these are all the things that come out when you really put it to test with real world cases. This happened to all 4 of the algorithms that we tested. And so what we learned is that without further refining of the algorithms using technical approaches that kind of tailor it to your local environment, these do not perform well out of the box, which was a little bit of what we're thinking about originally, how to use them. And then one of the big questions we asked is, are these algorithms fair? When we took a look at patients with darker skin tones, we've always been worried that these algorithms do not get trained with enough pictures of patients with black or brown skin in order for them to perform well. So what we did is we took 3 state-of-the-art algorithms and we took pictures of patients who were self-declared black with dermatologist-confirmed darker skin tones. And we took good spots, bad spots, melanomas, and then we matched them to patients with lighter skin tones with very similar diagnoses. And we confirmed the fear, which is that the performance of these algorithms drops off markedly when you use them on someone with darker skin tones. In fact, what we found is that in one of the most vaunted algorithms, again, that sensitivity dropped by 46% of getting a correct answer if you have a skin cancer, if you have darker skin tone compared to if you have lighter skin tone. But the bright spot here is that if you do some technical approaches like fine tuning, where you retrain it on more diverse images of people with darker skin tones, you can completely rescue that drop off. So it gives us a path forward on how to make this more fair. Now, I'll make one final point, which is that I know a lot of people here probably have a burning question. Why don't we just take these algorithms and release them to the general public? Let's just try and get spots as soon as we can. And this experiment has been done in real life, actually, in the Netherlands. So they made one of these state-of-the-art algorithms available to 2 million people in the Netherlands through this insurance scheme. And then a pretty large number of people downloaded it and used it, and they matched it to patients on that same insurance with similar characteristics to see what happened. Well, actually, some good happened. 32% of those of that group that used the app had an increased rate of getting skin cancers or pre-cancers diagnosed. So that's great. That's increased access to earlier diagnosis, hopefully. But a whopping 400% more people ended up at their primary care doctor being told, don't worry about that spot, essentially false alarm, untold anxiety, worry, and they did not even measure what happened to your primary care office. This technology starts sending a lot of people there for all sorts of skin spots. So this is kind of a key lesson. With AI, we're oftentimes going to walk a little this balance between increased access and a lot of unnecessary worry and false alarms. So kind of in conclusion here, our team has taken kind of a cautiously optimistic posture. We think that AI can really help us get diagnoses melanoma sooner, more accurately, and faster. However, what we know is this current generation of computer vision AI models, they're not ready to go out of the box. You have to do a lot of these technical approaches to make it more relevant to our local community, to our local environment. And that's especially true if you have darker skin tone. Very, very important. And then the final thing is that no matter how good the algorithm is, depending on where you deploy it, there's going to be a really important balance between making it available and increasing access, and then kind of overloading our healthcare system and creating unnecessary worry. So we think that there's a lot to do here. This is where a lot of our work is now going to be focused on. And we think that having a doctor or other provider in the loop is going to be a way to strengthen this. So thanks, everybody.